RG. So we have someone who's coming in with abdominal pain. As both Prof. Rez and Robbie has taught us over the years, is that in medicine, tempo is king. So I think it would be the differential for abdominal pain is quite broad, but I think the tempo will really allows us to hone into anything hyperacute, acute, subacute to chronic that would drastically change our approach to abdominal pain. But I would say though, when people are coming in with abdominal pain, I would always try to run my emergent causes of abdominal pain. And I heard of acronym VIPO when I was in residency. That stands for vascular pathology. So thinking about also, MIs that can portray as abdominal pain. So your vascular pathology, your itises, cholecystitis, your appendicitis, P4 perforations, O4 obstructions. And then I always add the ectopic pregnancy to that list as well. So that's a list that I try to run when people come in with acute abdominal pain. And then after that, I tend to like the anatomical approach to abdominal pain. I'll stop there and see if RG has anything to add.
VIPO. I love that. That's superb. I will tell you that that abdominal pain, I think the way we teach abdominal pain is a great way of understanding abdominal pain. I think there's a whole different layer of knowing how to diagnose somebody with abdominal pain in real life. And Shakespeare comes to mind and his famous question, to be or not to be. And when life is about abdominal pain, the real question is to scan or not scan. And there are two things that happen in real life when you're wondering about how to diagnose somebody with abdominal pain. And the first question is, do we need an answer? Many patients who have mild abdominal pain without alarm features are given working diagnoses like constipation or GERD or things that cannot be proven because they appear so well and there isn't an urge for the diagnostic answer. And then the real question is, do you scan or not scan? Because there are only, and I will tell you, there are only 7 causes of abdominal pain that one can diagnose for sure before a scan returns. These are things like zoster, hernia, pancreatitis, and as Charmaine mentioned, inferior myocardial wall infarction. So what I think we're going to listen for when Katerina has time to tell us more is, one, do we need an answer today? And the answer probably is yes. Otherwise, this is going to be an unfortunate virtual morning report with constipation. And then 2, are we going to be able to get an answer before we scan? The overwhelming odds are that we'll find something the overwhelming odds are, since the pain is located in the right lower quadrant, that we'll need to take some sort of image. And of course, I'll just say one final thing. We often take an anatomical approach to abdominal pain as a parallel thought process of to scan or not to scan. And when the pain is in the lower quadrants, it really is important to take an inventory of what organs are at play. And a proxy of that is what your patient's gender is. And you will have to wonder if the pelvis is in play here. And you'll have to wonder if you need to send a pregnancy test and or do a pelvic exam. So those are the things on my mind. All right, Katerina, back to you.
Okay, so this was a 46-year-old woman who presented to the emergency department with a sudden onset right lower quadrant abdominal pain that was constant. The intensity was 8 out of 10. She identified no precipitant factors, and she only took acetaminophen with partial improvement. She also had fever in that day. Her maximum temperature was 38.5, asthenia and anorexia. So all of this happened in one day. And on review of systems, she had no other complaints. No pelvic complaints, no urinary complaints, abdominal complaints like diarrhea, abnormal feces, nothing else, or respiratory, no chest pain, nothing, just this abdominal pain and the fever. I'll pause there.
Yeah, maybe I'll just reflect on the tempo, which is really key here, the fact that this was sudden. and leave the rest for Charmaine to analyze. And sudden, you have to be careful when somebody says sudden, because it may represent the sudden development of a problem or the sudden recognition of a problem. And Reza will hate me if I tell you my cataract story again, but it's all too often that we have patients come into the emergency room whose sudden vision loss is because they suddenly realize they have a cataract that's been there for years. And the way they might suddenly realize that they have a cataract is when they cover the eye without a cataract and see, whoops, I can't see. And so here the key question is this sudden recognition or sudden development? The way you might invoke sudden recognition is the patient has a slow growing process in her right lower quadrant that gets acutely diseased, like an acute infarction or acute torsion or an acute problem like that. But if you really believe that the sudden is actually a sudden development, then the calculus is what ruptured, what obstructed, and not so relevant in the right lower quadrant, but was there a sudden discharge of electrical activity? Those are the three things that can cause something to happen in the flash of a moment, something blocked or something ruptured. And that thing could be a vessel or it could be a hollow viscus. And of the things that I know of in the right lower quadrant that can have sudden development are perforation of the GI tract or torsion of the gynecological tract or the ovaries specifically. But there are a lot of other factors here that I'll pass on to Charmaine to analyze.
That was beautiful, RG. And I just have to do a quick shout out to the wonderful Dr. Eric Strong, who's joining us. It's so good to have you here, Eric. Thanks for joining. I love that, Robbie. And what I'm going to do is just kind of layer on the other aspect of this case, that is patient is febrile up to 38.5. And at CP Solvers, we do love the wonderful Reza's mnemonic of IMAID in terms of like a translating fever to inflammation and thinking about our infectious etiologies, malignancy, autoimmune. In this specific patients, the other thing that comes to mind, our GI tract is full of bacteria, and anything that can cause translocation of bacteria can potentially cause fever. So all the things that Robbie mentioned can potentially, by just the virtue of like the translocation, cause an inflammatory response and inflammation. So I think again, it kind of speaks to I'm not sure if it like completely changes my differential diagnosis at this point. I think, as Robbie mentioned, the problem is like whether to scan or not to scan, but given the acuity, given the evidence of inflammation that is going on, I think this is someone that, you see a scan in their future at age of 46. Getting a good like menstrual history is important. I think when you're evaluating a patient down in the emergency room, again, she's a woman. If she is still not postmenopausal, then you want to definitely do the pregnancy test and also keep that ectopic in the back of your mind as well. And the other thing that I always like learned from Robbie is that, when you think about abdominal pain, don't forget the neighbors of abdominal pain as well. So that is your thorax. So thinking about your lungs, thinking about your cardiac, and thinking about the pelvis. So I'm curious to get to know a little bit more background about this patient, who the patient is, the vitals, and then we'll go from there. Anything else to add, RG?
You wish that this patient would go to the scanner before they came to you. And I think the only thing that stands in the way, practically speaking, is to make sure you send a pregnancy test. And no, I think that that's the most efficient way to take care of this patient, and I look forward to getting that data.
Okay, you guys are awesome, like usual. So to explore this a little bit further, she started menstruating when she was around 10 years old. Her cycles were always regular. Her periods usually were 3 days of duration, and her last menstruation was around a week ago. She never used any hormonal contraceptives, and she was pregnant twice, and she gave birth by C-section. The last time was around 10 years ago. So this is a woman with a past medical history of SLE, with pleural and pericardial serositis, with photosensitivity and malar rash, polyarthritis, leukopenia, and secondary Sjogren's. This diagnosis was made around 15 years ago, and she tried many different medications until she found rituximab, and that's her current therapy. But she missed her last cycle because of scheduling conflicts, and since then her leukocytes have been falling pretty steadily but surely, and her anti-dsDNA has been rising as well, but with no consumption of C3 or C4. Yeah, her medication is only vitamin D and her rituximab. She never smoked, never drank, no drug use, no allergies. Her only sexual activity is with her husband, but it's protected because she doesn't use any other type of contraception method. And she is pretty sedentary because she's a lawyer. And her family history is irrelevant, as is the rest of the social history. Going into the physical exam, she looked well, in no acute distress. Her BP was 125/89. Her heart rate was 92. Her temperature was 36.2 Celsius. Respiratory rate was 16. And she was sitting at 98% on room air. So she had no skin abnormalities. Her lungs were clear to auscultation. Her cardiac auscultation was also clear, no murmurs. Her abdomen was soft, but was very tender to the palpation of her right lower quadrant, but with no rebound pain, but a little bit of guarding. The rest of the exam was absolutely normal. Yeah, I'll pause.
Yeah, I'm just such a big fan of you. Just working at 1 a.m. in the ED, presenting a case, just fantastic.
I have to do a Reza interjection because clearly you're a fan of Katerina, and Katerina's maybe not a fan of lawyers. Just she's very, very sedentary because she's a lawyer, obviously. Oh my gosh. Oh, I almost died, Katerina. I almost died.
She told me she was sedentary, guys. Come on.
Oh, okay, I'll shut up. Shut up.
Okay, maybe I'll just focus on a little bit on the background information, and then I would love to hear you add to that, RG, and then take us through the exam. So the lupus history is quite fascinating, and I'm also the amount of complications she's had from this her lupus. It's quite impressive. So then the question becomes like, is this her background history, this lupus, is playing a role in this pathogenesis that is going on, or is it a red herring? Just like we think about patients with HIV and immunodeficiency, that that it could be related to that, but they also can have any other causes of abdominal pain, any other causes of inflammation that someone who doesn't have lupus or doesn't have HIV can get. In terms of like thinking about like the lupus and the GI symptoms, thinking about this abdominal pain, lupus enteritis comes to mind. That is actually quite rare, I think. And that usually focus on jejunum, and it can also happen as any other flares is happening with patients underlying lupus. And the other thing that can also happen is vasculitis type pictures with lupus. It's usually tends to be more medium vessel vasculitis affecting the GI tract as well. It's noteworthy that she's just having abdominal pain and no other diarrhea or anything else that we yet know of, although it's the presentation is quite abrupt. RG, anything else that comes to your mind in terms of like lupus and abdominal pain?
Yeah, I think it's funny that when you overlap lupus with anything in the body, you can do a lot of hypotheses generation, but the manifestations in the GI tract are much less common. And the disease that devastates patients with lupus that is in the abdominal retroperitoneal area, namely end-stage renal disease or glomerulonephritis and many other manifestations, is not painful. And yeah, then you start to enter the world of esoteria, and I think the most common is lupus enteritis, which is a vasculitic phenomenon. Um, and then, lupus serositis, which notoriously, as Katerina reminding us, affects the thoracic area, can affect the peritoneum itself. So peritonitis, sterile peritonitis, is something to think about for sure. And then the other dimension of it is the fact that she's so immunosuppressed, and I think the immunosuppression here expands the horizon to a whole variety of infections, which we would only speculate on when we know the nature of the syndrome and where she's been, her epidemiological exposures. But I think one infection that deserves special mention is gonorrhea, not because of the rituximab, because patients with lupus have complement deficiency, and so disseminated gonococcal infections are more common in these patients. So you want to have that disseminated Neisseria infections, either Neisseria meningitis or Neisseria gonorrhea, are more common. And I think the exam, just to move through it really quickly, just tells you, hey, that not only is she immunosuppressed, she's localizing to something in the right lower quadrant. And I think the real question in the ER is, can you decide if you can get CT imaging or a pelvic ultrasound? And a pelvic exam may help you make that distinction. It's not uncommon that we get both because the sensitivity of each is imperfect. And many people have missed pelvic inflammatory disease for appendicitis or vice versa. And I am one of them, as Reza will attest. He presented a case on RLR of what turned out to be PID, but I thought it was appendicitis. So I think what I would do in real life is a pregnancy test at point of care, and then make a thoughtful decision about how to take a picture, either with a CT scan or with a pelvic ultrasound. And if I couldn't commit one way or the other, I think the CT gets me more than the pelvic ultrasound. So I'd probably start with that. But I'm reminded from Reza's case that the timing of this may not be coincidental. The fact that it's occurring 3 days after her last menstrual period, it's a time where the cervical plug that typically protects the higher genital tract, namely the endometrium and the fallopian tubes, that plug is dissolved around this time. And so there's a higher rate of PID shortly after the menstrual period. So there's a lot to play here, but radiology is probably going to help you more than anyone else. All righty, Katerina, back to you.
Okay, here we go. There was a bet going on in the chat about her white blood cell count, and nobody won. Her white blood cell count was 3, mostly because she had a lymphopenia of 0.8. Her neutrophils were normal. Her hemoglobin was 12.7, and her platelets were 249. Glucose 100, creatinine 0.6, BUN 16, T-bill 0.45, AST 22, ALT 28, ALK Phos 91. Her CK was 18, and her CRP was 216. Sodium 139, potassium 3.6, chloride 104. Her UA was absolutely normal, completely innocent. She was seen by gynecology that did a pelvic exam that was also normal. So we opted to do first an ultrasound, and her abdominal ultrasound showed a little bit of fatty liver, but otherwise normal, and her appendix was perfectly normal. Her pelvic ultrasound was also normal. Her ovaries had no cysts, no lesions. Her uterus was also normal, and there was no ascites, and her bladder was empty. And she also did pelvic ultrasound via endocavitary, and it showed no other findings that weren't seen before. Yeah.
Alrighty, well, what I'll do is I'll just tackle the labs and leave the imaging for Charmaine to analyze. And the labs are very helpful. The story of a lupus flare is often one that involves a flaring of symptoms compatible with lupus, but the laboratory signature in unison is very helpful. And the laboratory signature is a drop in the white blood cells. It's basically a drop in all cell lines. The most specific drop is that of white blood cells. And then an increase in the anti-DS DNA level if it was positive before, and a drop in complement levels. That pattern is very helpful. And you start to see a little bit of that pattern, at least with the leukopenia, but there's two problems with that. The first is that a notorious cause of a drop in white cells is sepsis. It's actually one of the SIRS criteria if you use SIRS, so that you have to temper your enthusiasm for leukopenia, augmenting the concern for lupus flare. But the more robust evidence that argues against lupus flare is the CRP. So most patients with lupus, they have a very unique pathophysiology of inflammation that does not include IL-6, which is the proximal marker that then elevates CRP. So typically a CRP elevation is a strong argument against the diagnosis of a lupus flare. But like medicine, your tongue is going to get twisted because there's an exception to that. And that exception is when your patients have lupus serositis. The serositis, for some reason, is actually IL-6 mediated, and so the CRP can go up in that situation. So unless you have a compelling reason to believe the patient has overt signs of a serositis, you should take a CRP as evidence that there is a non-lupus related inflammation present in your patient. This entire conversation presumes that you can't have a lupus flare and an infection. Of course, that's flawed reasoning. Your patient could have both, but here the CRP either can be used to press full throttle on the gas to look for an infection, and at the same time work up the possibility that you actually have lupus serositis here. All right, I'll pass the mic to Charmaine for the imaging and anything else she wants to talk about.
Robbie, I did not know about the serositis and the CRP, so thank you for teaching me. That's such a great pearl. Yeah, I 100% agree with you. In my mind, lupus flare was going a little bit down because of the CRP, but I think serositis is a really great point, and also just getting the double-stranded DNA, the complement level. And what I really, really love about the work that is done already is like thinking about the pelvic etiology of it and ruling that out. They did a fabulous job of that. I would still get a CT imaging. Just a patient can have just diverticulitis and a lupus flare, or not at all. So thinking about like common things being common too, I think in this someone with who is immunocompromised, who has underlying diagnosis of lupus as well, coming in with acute abdominal pain, then CT imaging would be very informative. And then the next step is, depending on the CT, we might have to kind of think through the CT negative abdominal pain. I really like a RESA schema on that and see where that takes us. But I think that's kind of the logical next step. I'm curious to see if they did that and what it shows.
Okay, I forgot to tell you, but the pregnancy test was negative. So yeah, we did a CT, and that was very helpful because it showed a tubular structure going all the way from the vena cava to the inferior, the lower right quadrant, that was consistent, but not vascularized, and was consistent with right thrombosis of the right ovarian vein. Yeah, and I will pause.
What? It is a Katerina case after all. Did not expect that. So a thrombosis of the right ovarian vein. I think then the question becomes like, is this explains the patient's presentations. So going under the hypothesis that let's say it does, and thinking about like why this vessel thrombose, is it related to his underlying autoimmune etiology? Is there any local thing that is going on that has caused an infection and then the thrombosis there? Is there any other systemic reasons for thrombosis? So at this point, I think it's valid to think about the etiology of where this clot is coming from. Well, RG, what are your thoughts? This threw me for a loop.
100%. It's thrown me for a loop too. And it's, pelvic vein thromboses are very rare. I would step back and say, am I sure this is a bland clot? Because I think, remember one of the first things that caught our attention was this is a fever of 38.5. So for me, whenever you see something in a vessel, you want to ask the simple question of, is this thrombus? Which of course a patient with lupus whose disease activity might be flaring, who might have antiphospholipid antibody syndrome, that's totally fair. But you want to step back and say, is it something else? And there are many things that can cause thrombosis, but the most acute thing would be to worry about pus. And septic thrombophlebitis of the pelvic veins is a very well-described phenomenon that occurs typically in the postpartum state. As a result of the progesterone's effect on the vessels, it dilates. The pelvic veins are very, very big in and around pregnancy for reasons that have to do with how much perfusion goes in and out around pregnancy. And so here you really have to step back and say, yes, this patient is at risk for thrombosis by virtue of lupus, and there's evidence to support the idea of lupus flare, but the CRP and the fever here have me concerned and make me wonder, is this actually pus? And, if this were, for example, you flip the anatomy here and you say that there's a clot next to the throat, you would call this Lemaire's disease and you would think of Uncle Bob right away. And so for me, the question now is, one, I don't know the space as much as I would love to, and in real life you would be leaning on your gynecology, but through analogic reasoning, I'm worried, and I'd be most worried that this represents pus. And the only good thing about pus in the vascular system is you usually can culture the causative organism very quickly. So I don't think I would have a hard time giving this patient antibiotics in the ER and being wrong about it. I wouldn't have a hard time sending APLS serologies in the ER, but I would be leaning heavily on gynecology and worried that she might have septic thrombophlebitis of her ovarian vein. Yeah, thoughts about that?
No, I totally agree, because I was like thinking, is there anything local infection going on within that is causing it? I'm right there with you. I think infectious workup. The other thing that I always say about APLS workup, I like learn it 10,000 times, and then patient shows up and I'm like, is this the right time to send serologies? Just to note whenever you're sending it died, and the clinical context is really important interpretation of it. And that's one of the things I really rely heavily on a hematologist, because it's just really hard to interpret. But I cannot wait to see what happens next.
And I'll just say the one final thing is it's very satisfying that the sudden onset hypothesis was actually reinforced. So you always want to, now it makes sense that attributing causality to this finding is certainly supported by the fact that she had an abrupt obstruction of her vein. All right, Katerina, back to you.
Okay, so final aliquot, what happened? Her blood cultures were sterile, multiple sets. So we basically put our money on anticoagulation. And so that's what we did. We started her on Lovenox, and truth is, everything resolved. The fever resolved, her CRP dropped precipitously, and her pain absolutely resolved. And then we transitioned her to warfarin because on further workup, he had APLS, triple positive APLS. So yeah, the final diagnosis was APLS secondary to SLE, complicated by right ovarian vein thrombosis. Yeah.
Wow, Kat, what a case. Thank you so much for presenting this. We started the journey with abdominal pain, acute abdominal pain in a woman with a background of a lupus, and we ended at SLE. an APL SLE causing and being associated with the APLS. That's such a fantastic case. Kat, anything from this taking care of this patient that you want to share? Any other pearls before we hand the mic to Promise?
Basically, what I learned was that you can get thrombus everywhere. Yeah, and this is pretty rare. I presented this case that ran rounds in my service, and everyone was like, I have never heard of ovarian vein thrombosis before. And I was like, me neither. And yeah, last thing, the thing that this really reinforced to me was that, yeah, thrombus can cause fever and a systemic inflammatory response. And we always look at high fever and high CRP and we say, this is infection. And yeah, we have to think about that until proven otherwise. But, you know, thrombus has a lot of stuff happening in it and it causes a lot of inflammation. So yeah, it can be explained just for that, just because of that. So yeah, that was my biggest. Yeah, go ahead.
Can I make a quick interjection? I have to make an interjection because I see Ravi's face and Sharmizi's. I'm like, I used to think that clot cannot cause fever. I went on record on Twitter saying this. And then this amazing resident at the time, who I believe now is a fellow, did a whole tutorial as to why I was wrong. And it is just phenomenal. So this is done by Jonathan Ryder. I included it in the chat, but goes into the mechanism by which clot causes fever. And he was very kind to me on Twitter. But anyways, that's for everyone in the audience to review at your own leisure.
I was worried we were going to make it 30 minutes without a Prof. Rez interjection. And I was like, oh my God, the world is normal again. Yes.
I know. I'm so happy he did.
Woo! Can I share one really ironic thing? I love Jonathan. I think I learned so much from him, but I find it so ironic that an ID physician now, he's an ID fellow, ID physician argues for anything other than infectious disease causing a fever. I love it so much. Yeah, I'm Googling in real time about ovarian vein thrombosis, and I literally cannot find anything on Google outside pregnancy. So Katerina, this might be a really good case to get out there in the literature for people to start to know of non-pregnancy related disease. This is so
yeah.
cool. Thank
you.
Yeah,
I'm on it.
Wonderful. Alrighty, I think we're ready for Promise to take us home.
Okay, hi guys. So this is a very interesting case with a 46-year-old coming in presenting with pain in the right lower quadrant and fever. And she pretty much doesn't really have any other complaints besides having a history of lupus. And so when we're thinking about her presentation, we first start broad and thinking about different etiologies, like from the heart and then abdomen, but also because it's right lower quadrant, we would also think about the gynecology aspects of it. So like having a pregnancy or a torsion or like PID. And then when we found out that this patient has a history of lupus, then we start wondering if the lupus is playing a role in her symptoms or if it's just in the background. So we talked about lupus enteritis, medium vessel vasculitis, and also peritonitis. And then we also don't want to forget about infectious causes, because patients with lupus have complement deficiency, so they're more susceptible to this area, and especially because she has a fever. And then Robbie gave a good parallel about how in lupus, usually we would see a drop in white blood cells and complement levels, but the fact that we see this patient with an elevated CRP, it can kind of lead us to think a little bit less about this being a lupus playing in the background. But it turns out that this patient has, lupus is associated with like antiphospholipid syndrome. And so that's pushed this patient at a higher risk of forming thrombosis. And I think I vaguely remember learning from pathology class that people with antiphospholipid syndrome would have like anti-cardiolipin lab positive. So I think it's just a great learning case knowing that we should think about seeing a thrombosis in the ovarian vein and then seeing this being a female with an autoimmune lupus history to think about having antiphospholipid syndrome. Thank you so much for this great case, Katerina. I learned a lot.
Promise. Thank you so much. That was fantastic, friend. Thank you so much for doing the teaching points. It's such a hard skill to take pearls from as the case is evolving, write them down and then present. So I really appreciate you. Andrea, thank you so much for scribing. Kat, you're brilliant as always. Thank you also so much for joining us. This is always a highlight of my week. See you all tomorrow. Bye.